So what exactly are leukocyte antibodies? Well, these are antibodies that react to blood cells that are foreign. They're also called blocking antibodies. The theory goes like this. After repeated exposure to a partner's cells, through semen, for example, the body may produce antibodies that help the immune system recognize and tolerate the partner's genetic contribution.
In other words, these antibodies were thought to act like a peace treaty. Instead of the immune system treating the embryo as foreign and as an invader, the antibodies would help it to accept the pregnancy. Welcome to my fertility podcast, Superhumans, the show that brings you expert insights, personal stories, and the latest in fertility care, all in one place.
Whether you're starting your fertility journey, navigating challenges, or just exploring your options, we're here to empower you with knowledge, support, and hope.
Join us as we dive deep into topics that matter most, from IVF and fertility treatments to mental health and wellness.
I'm Dr. Mavis Garcia.
And I'm Dr. Wise. We're two of the fertility specialists at Markham Fertility Centre in Markham, Ontario, Canada. Think of us as your sisters in all things fertility. Let's demystify the world of fertility together.
Hello, superhumans. Here we are in Markham, Ontario, recording today with another episode of my fertility podcast. If you're new here, we're so glad that you found us. And if you're one of our loyal listeners, thank you for sticking with us. Today, we are exploring the fascinating and mysterious and complicated topic of the world of the immune system and the impact that it has on fertility.
That is right. So, bit of a recap here. In previous episodes 72 and 76, we talked a lot about recurrent implantation failure and all of its potential causes and the workup and potential treatment options. And one of the things that we talked about was immune system dysfunction. Now, we have received so many requests to go into more depth about this, and so we're doing a whole series on the immune system, the testing, and the treatments and protocols. In previous episode 78, we introduced the immune system in pregnancy, why the body has to walk this proverbial tightrope between protecting you as the person who's pregnant and also allowing an embryo, which is genetically half from someone else, genetically half foreign often, to implant and grow.
And specifically in this episode today, we are digging into something that many patients are asking us about. And that is the leukocyte antibodies and the immune therapies like lymphocyte immunization therapy or LET. You may have seen these terms in fertility forums, on social media, and they can sound very confusing and even a little scary. So let's unpack what they are, where the idea comes from, and what we know.
All right, so let's build on what we talked about last time. So again, think of the immune system as your body's security team. Their job is to patrol, identify intruders, and take action.
But in pregnancy, the security team has to do something unusual. It has to stand down in some situations. You see, the embryo is a mix of the DNA of the egg provider and the DNA of the sperm provider. From the immune perspective, it's basically a foreign body. Normally, the immune system would want to reject anything that is foreign, like a flu virus or a transplanted organ, for example. But in pregnancy, it has to actually recognize it and learn to accept it.
And usually, more often than not, the body is actually incredibly good at this. There are so many checks and balances and, special immune cells in the uterus and signaling molecules and hormonal changes that help the immune system adapt for this. But when things don't go smoothly, some scientists and fertility physicians have wondered if immune rejection could be a part of the problem.
So when things go wrong from the immune system point of view, we think it shows up clinically as recurrent implantation failure or recurrent pregnancy loss. For reference, we talked about recurrent implantation failure in episodes 72 and 76 and recurrent pregnancy loss in episodes 51 and 56. When you listen, you would see that we talked about the fact that there is no universally accepted definition for either of these conditions. But recurrent implantation failure is usually thought of as repeated failure of 3 to 4 good quality embryos that have been transferred in ideal situation but failed to implant. This means doing multiple rounds of embryo transfers and getting negative pregnancy tests.
So, RPL, or recurrent pregnancy loss, is again thought of as maybe 3 or more miscarriages. The number of miscarriages is not agreed upon amongst, the greater fertility community. And some definitions also talk about the miscarriages being consecutive. Again, this just basically means that embryos are implanting, somebody might be getting a positive pregnancy test, but the pregnancies are ending or stop growing at some point after that, typically in the early to mid first trimester.
So, what exactly are leukocyte antibodies? Well, these are antibodies that react to blood cells that are foreign. They're also called blocking antibodies. The theory goes like this. After repeated exposure to a partner's cells, through semen, for example, the body may produce antibodies that help the immune system recognize and tolerate the partner's genetic contribution.
In other words, these antibodies were thought to act like a peace treaty. Instead of the immune system treating the embryo as foreign and as an invader, the antibodies would help it to accept the pregnancy.
Now, LAD testing or leukocyte antibody testing measures how much antibody reacts with a protein that is not self. In other words, it does not come from the person carrying the pregnancy. Production of blocking antibodies act as an immunological regulator to preserve the pregnancy, essentially shielding paternal molecules that are expressed on the fetus from the immune system. Another way to think about it is like this. Leukocyte antibodies appear to protect the pregnancy by preventing or blocking the damaging immune response to fetus that contain foreign proteins that would be coming from the sperm provider.
In practical terms, when we're actually thinking about the test, what happens is that the person who's carrying the pregnancy, often the female, her serum, which again is a part of the major component of blood, gets incubated with white blood cells from somebody else. This is why when we're doing an LIT or when we're actually running the testing for these leukocyte antibodies, we require a blood sample from both the person whose immune system we're testing or the carrier of the pregnancy and someone else, which is most often the partner. Now, again, the two types of cells are incubated together and the resulting T cells and B cell antibody production is measured. A higher percentage is considered better or more protective of the pregnancy. So in this test, in this case, higher numbers, higher results are better.
And that brings us to LIT, or lymphocyte immunization therapy. LIT was developed in 1981. It was the first immunomodulatory treatment that has been suggested for recurrent pregnancy loss. And here's how it works. The white blood cells are taken from the partner, most often, sometimes could be from a donor, and injected into the patient. The idea is to stimulate the body to produce these blocking antibodies, which in theory could help protect a future pregnancy.
Now, there are a couple of really important points about LIT or LIT. Number one, the donor lymphocytes must be injected just below the surface of the skin, or something called intradermally, so that they can interact with a specific cell type in the skin called dendritic cells. Also, the exact protocol varies center to center. And this treatment or inoculation is often repeated multiple times until a sufficient immunologic response is developed. Many centers, including here at Markham Fertility Center, we do it twice, using 2 doses or 2 treatments about 2 weeks apart. Usually, a period of 4 weeks is considered adequate for development of maximal protective response.
So, what is LIT or LIT actually like? Well, here at Markham Fertility Center, the LIT injections are done in the forearm. The donor, which is usually the partner, will have the blood drawn, just like getting regular blood tests, and multiple vials of blood are collected. The blood is spun down in a centrifuge to isolate just the white blood cells. Then the injections of the white blood cells are done by a nurse. The injections are very quick as it is drawing the blood, but the preparation time between these procedures is about 2 hours.
Shortly after the injection, when we're thinking about different side effects, very early on, sometimes people might have a bit of a bluish mark at the area of the injection, usually disappears in about 2 or 3 weeks. Sometimes people will have blisters form. They might get a bit of a rash on the skin. They might have some hives in and around the forearm. Very rarely, people will have enlarged lymph nodes, especially in the armpits. You might get a mild fever, some fatigue, headache, dizziness. It's possible, but very rare to have nausea or vomiting. It's important to note that an anaphylactic reaction, like a full-blown serious allergic reaction, which is called anaphylaxis, has not ever been reported in the literature. It's also worth noting and emphasizing here that the extent of the reaction, like how many side effects a person has, does not predict whether the LIT is working or helping.
This was actually quite popular in the 1990s and early 2000s, especially outside North America. There is a number of clinics all over the world that are still offering LIT today, but here in Canada, there are very few, and none of them are present in the United States, and we're going to talk about that more later.
On the surface, this sounds really clever, actually, right? Like you're training the immune system to recognize an embryo and accept the embryo. But there are really important concerns that we're going to talk about. Number one, the safety of injecting someone else's white blood cells into somebody else, including the risk of infections. And then, of course, the question of whether this actually helps or not.
In the United States, regulatory agency like the FDA has said no to LIT. It is not approved. The FDA actually suspended LIT in 2002, citing research that it was ineffective. It can only be done as part of a research protocol. The World Health Organization also does not recommend LIT due to lack of evidence and potential side effects.
The problem is, over the years, studies haven't consistently shown that having or not having these antibodies really predicts fertility outcomes. Some studies have shown a positive association, others have shown no effect at all.
And this is where things get very tricky, because for patients who have gone through multiple losses or multiple failed IVF cycles, it's natural to want to have an explanation and even better, a treatment. If a test comes back saying no blocking antibodies, it can feel like finally there is an answer because there is something that we can do to increase those blocking antibodies. But the science doesn't support using this as a reliable marker for infertility or recurrent pregnancy loss.
So first of all, is LIT safe, right? Because as physicians, we're always thinking about first do no harm, right? And the Hippocratic Oath. At first, there was a thought at one point that LIT may actually predispose someone to developing autoimmune disease later on, which could be potentially really serious. Again, if you're injecting foreign cells into the patient, you might create this thing called microchimerism, where there are foreign cells persisting with quote-unquote self cells, and this could predispose the autoimmune system to act up. However, studies have proven that this does not happen and that having LIT does not seem to predispose somebody to having an autoimmune condition later in life.
Another concern with LIT is that it might predispose somebody to have what is called graft versus host disease. If foreign cells enter somebody else's blood circulation, those cells can attack the recipient's body because, from their perspective, the cells are foreign. It can cause symptoms like skin rashes, diarrhea, or liver problems, and some of those symptoms could range from being mild to severe. Studies have shown that LIT does not predispose someone to graft versus host disease, but it can theoretically happen if those white blood cells are injected into someone else's circulation instead of intradermally.
Probably the biggest concern with LIT is the risk of transmitting infection. So there are lots of bloodborne infections like hepatitis B, hepatitis C, HIV, and we know that these things can lead to very serious illnesses. Yes, we have tests for these infections, but they're not perfect. There's always a chance that somebody could have a false negative test, or that someone's infection is very new or recent, and that their test comes back negative when it will eventually become positive a little bit later, and they can still transmit the illness. Probably the best analogy is talking about a blood transfusion. If you get a blood transfusion, there's always a risk of infection. The risk is relatively low because blood in Canada goes through rigorous screening by Canadian Blood Services. Also, blood transfusions are generally given as a life-saving measure. So this plays a really big role when the patient, the physician, the full care team is considering the risks versus benefits of this treatment. With LIT, the benefits aren't so obvious, and we're going to talk about that shortly.
Speaking of the side effects, you know us and we like to present you with evidence and studies. There was one study published in 2006 by Klein et al. It followed 3,000 patients that have undergone the LIT procedure. They documented that there were no acute allergic reactions, no increase in autoimmunity or graft versus host disease, and the local side effects, for example, a rash, happened in about 8% of patients.
Another important consideration for any kind of fertility treatment is, of course, the risk to the pregnancy and the potential baby later on. There was a study back in 1994 by Coulomb et al., where they found there was no increase in fetal complications, so things like preterm birth, intrauterine growth restriction, or fetal death, or other neonatal complications, if the person who's carrying the pregnancy underwent LIT treatments.
So now that we have gone over the evidence showing that there is a good number of studies that show that there is no increased risk of autoimmunity or graft versus host disease, now let's get to the big questions, because that's what you really want to know. Does LIT actually work? The big study that is probably the most talked about is the REMIS study. It was published in The Lancet, and it was a randomized controlled trial that took place between 1992 and 1997. It was multi-center, so it means that it looks at many different centers, double blind, which is really important. It means that neither the doctors or the patients knew whether the participants were getting LIT or placebo, and it was randomized. This study was not on women after IVF. It was spontaneous conceptions. It's important to know this study was not done in women that had recurrent implantation failure after IVF or recurrent pregnancy loss after embryo transfer. It was done only in women that had conceived spontaneously and had had miscarriages in the past. Women that had recurrent pregnancy loss after conceiving spontaneously did not have a lower risk of miscarriage after having the LIT procedure. As a matter of fact, in the control group, so the patients that did not have an active LIT treatment, 65% of those that became pregnant carry on to have a live birth and did not have a miscarriage. In the LIT group, the patients that actually had the LIT, 46% of the patients who became pregnant did not have a miscarriage.
Let's take a closer look at this study, and let's get into it. In this study protocol, the blood used for the LIT treatment was stored in a refrigerator for several hours prior to use. Critics of the study argue that this destroyed the immunomodulatory effects of the cells. Also, the study, the REMIS study, allowed participants to do LIT as little as 2 weeks prior to conception. This may have been too short of a time to develop a good or a true immune response.
How the injections were done also really varied a lot between centers. We think that where the injection is done, what layer of the skin, has a major impact on the effectiveness of the treatment. Critics of the study also noted that the concentration of cells after the preparation of the sample was not uniform in all cases.
A Cochrane review is a type of very high-quality scientific paper that summarizes all the available research on a specific healthcare question in a systematic way. Very often in medicine, we turn to Cochrane reviews, and they're very highly respected generally, and they're considered a very high level of evidence. In 2003, there was a Cochrane review on LIT, and it was very heavily influenced by this particular REMIS study. Subsequent Cochrane reviews in 2006 and 2014 have concluded that LIT has no beneficial effect on prevention of miscarriage, an increase in the live births in patients with recurrent pregnancy loss and recurrent implantation failure.
But again, it's always important to have a critical eye to this. There are many critics that take issue with each of the Cochrane reviews because of which studies were included and how much variety there is between the studies, which makes it really difficult to draw conclusions and make statistical calculations.
This is not uncommon, okay? So for many topics in medicine, at least, when there is controversy, it can be really hard to convince critics with evidence. Perfect studies, perfect data simply does not exist. Anytime some really big, quote-unquote, groundbreaking study comes out in medicine, many people will take issue with how the study protocols were done, with the statistics, who was included, who was excluded, what variables were controlled for. Because again, perfect studies and perfect data does not exist. So the interpretation of all studies in medicine is always open to criticism.
This is a big area of interest, and there have been more reviews or more analysis. So, for example, in 2016, there was a new meta-analysis. Meta-analysis is a combination of trials that was done about this topic that included all the studies from the Cochrane review that we talked about, but it excluded the REMIS trial because we know all the problems with it, as we discussed earlier. So this was done in 2016. When the data was reinterpreted, it showed that actually the chance of a live birth improved after LIT. The odds ratio was 1.63, which means that the group that had the LIT had a 63% higher chance of having a live birth than the group that did not have the LIT.
And in 2021, there was, again, a new systematic review and meta-analysis that was updated. This time around, the study had 3,007 participants. And in this study, they found that women who had LIT had an increased rate of live birth with an odds ratio of 3.2. So this means that the chances of a live birth were 3.2 times higher after LIT than not having LIT.
These reviews were very positive. However, it's worth noting that the author very clearly and very ethically acknowledged that the quality of evidence was not great because many of the studies had small numbers of participants and they were not randomized controlled trials.
Basically, everyone agrees that we need more high-quality studies.
But yes, in the perfect world, we do need more high-quality studies, but they are really, really hard to get. For example, they are incredibly expensive. And in the case of the LIT, there's no financial backing. So when a new drug hits the market, the drug company will fund the studies to show that the new drug is safe and effective because they have an interest, they have a potential profit in the future. In the case of LIT, unfortunately, there is no financial motivation from any of the pharmaceutical companies. Also, recruiting patients would be very, very challenging. You would need thousands of patients to do a proper randomized control study. And more importantly, you would need thousands of patients that have gone through the pain and agony of recurrent pregnancy loss or recurrent implantation failure who would be willing to be randomized to get no treatment at all, which, as you could imagine, this will be very difficult.
I mean, I can certainly speak to my own experience. I remember being a fellow and I was trying to do a randomized control trial, not about LIT, but about something else. And actually, Dr. Chan was my supervisor. And I think over the course of 2 years, I recruited maybe 2 participants. Because again, when you're talking to a patient, when you're talking to a potential study participant, and you say, okay, there's this thing that might potentially work, but you're at risk of not getting that thing, then everybody basically says, well, just give me the thing that might potentially help, especially for patients who are desperate, frankly, and where there is not necessarily a great alternative treatment. I mean, the alternative is really to do nothing, right? In a lot of these cases. And so recruiting of participants is exceptionally difficult in the world of fertility. Now, when you're a physician and you're faced with a clinical problem or a clinical situation, we're often turning to guidelines that are written by these professional societies to help us determine what we should do in a clinical situation. And again, these are guidelines, they're not rules. It's worth noting here that professional societies have been pretty clear about LIT. So for instance, the American Society for Reproductive Medicine, or the ASRM, has said that immune testing and immune therapies for fertility should not be offered as routine care because there is that insufficient evidence of efficacy and safety because we don't have those, really good, well-powered randomized control trials that we keep talking about.
In a similar vein, the European Society of Human Reproduction and Embryology, or ESHRE, does not recommend LIT for recurrent implantation failure or recurrent miscarriages as part of a routine clinical practice. The ESHRE guidelines emphasizes that immunotherapies, including LIT, lack sufficient high-quality evidence for efficacy and safety and should not be considered the standard of care and should only be offered in research settings.
Now in Canada, we have the Canadian Fertility and Andrology Society, or CFAS. And again, they do not recommend LIT treatment for recurrent miscarriages or implantation failures, again, in routine clinical practice. This is very consistent with the consensus in the medical literature, as I think we've outlined very well.
We completely appreciate that this is tough to hear. When you are a patient that has been going through recurrent pregnancy loss or recurrent implantation failure, all of these guidelines feel like they're closing the door in your face because all they keep saying is that there is not enough evidence to offer you something that could help. In reality, these guidelines are there to protect patients from treatments that are costly, maybe risky, and not proven to help.
Absolutely. When I think about immune treatments in general and fertility patients, I really feel like we are walking a bit of a tightrope when we're talking to patients. Because on one hand, when I'm counseling patients, I'm sure when you're counseling patients, we're super clear about the fact that what the guidelines are saying, what professional societies are saying, and what the evidence is saying. But we also recognize that what these guidelines are telling us is that these things should not be offered as routine clinical practice or standard clinical practice. This is not some sort of, step-by-step algorithm. And emphatically, that is not what we do at MFC.
Yes.
Emphatically. Really, these are very, very nuanced patient discussions that we have. We talk about the evidence and we very clearly point out this. But again, the guidelines are not saying that this stuff doesn't work. They're just saying that it's not been proven to work because those studies are lacking. And again, those studies are lacking, as we've talked about, for many different reasons. And frankly, they're not coming out anytime soon, unfortunately. The fact matter is that when you have a patient with significant recurrent implantation failure or significant recurrent pregnancy loss, there is no specific algorithm or treatment plan. We don't necessarily have some great alternative that is proven to work. And that is the crux of this issue. And that is why when we're seeing these patients, we are talking about the whole smorgasbord of different treatment options that we talked about in the RIF episodes and in the RPL episodes. And part of that is a discussion around immune. And again, it is a very extensive discussion and decision-making process between the doctors and the patients to decide if this is something that is worth trying.
Yeah, you're absolutely right. To be honest, we get a lot of referrals from patients that are coming to Markham Fertility Center for the LIT. And in many of those consults, we have to go back to the basics and explain why LIT is not the right thing and why we reserve it for specific cases, which can feel really disappointing because sometimes people hear about it and they think, oh, finally a clinic that does it. But we're not an immune treatment drive-through. We're physicians that are really trying our very best to give you the advice and the treatment with the information that we have. So every single patient that is requesting LIT, we really determine whether it's the right treatment or not. And we go through a lot of all the things that we talked about here, what the evidence is, what the lack of evidence is, what the guidelines were saying. And generally, we do these treatments when everything else has been tried, when there are many instances of interventions that have already failed, and we're really at a position where we are up against the wall. And then the patients consent to the treatment with a full disclosure and discussion on the evidence or lack of evidence and what the guidelines are saying.
Let's go through some of the common patient questions or concerns that patients will often ask us. They might say something like, if my immune system is attacking my embryo, shouldn't I try something? The reality is that we don't necessarily have a super reliable test to know if that's really happening. And even if it is, we don't yet have a proven way to stop it.
There's a lot of people on social media that post about their stories. And they would say things like, hey, I tried many things and nothing worked. And then I did LIT and I finally got pregnant. And truth be told, I have a lot of those cases stories as well. And the stories are powerful, but they don't provide cause and effect. A lot of people do get pregnant after failed treatment simply by trying again. Now, while I love the stories, I'm always very careful about using those stories as a way to counsel patients. We still need to talk about the evidence or the lack thereof.
Some patients may also sometimes say, okay, we don't know if I don't necessarily need this, but what if I just do it anyway? Is there harm in just trying it or just doing it? The reality is, yes, there absolutely can be risks. As we talked about earlier in this episode, the risk of infection, bloodborne infections. And of course, it also comes with significant financial costs. And then also just the emotional impact, right? We don't want to give a false sense of confidence or a false sense of security that people do this thing, that things are for sure going to be better.
This reminds me, I had a case just last week of this lovely couple that came to me for a second opinion. They had been at a different clinic and they had had a really difficult journey with both recurrent implantation failure and recurrent pregnancy loss with multiple IVF cycles. And they wanted to do immune testing. Again, we had a long consultation about it. I went to the pros and cons and they did the testing. Then the results came back that the leukocyte antibodies were low. And then we talked about LIT. And they were so happy. They're like, oh my gosh, Dr. Garcia, we finally found something that is wrong and something that we can do to fix so that I don't have to go through this agony again, through this experience again. And, very sadly, I had to say, actually, I don't know if that's the case. I don't know if these numbers that I'm presenting to you are really the cause of your long, painful journey. And I don't know if this treatment is really going to make a difference. Yes, we have the numbers that are low. Yes, we have a treatment that can bring the numbers up, but unfortunately, we don't have the evidence to conclusively say this was the problem and this is going to be the solution. And honestly, that was really hard to do because they have come to me with all of this hope. And of course, I explained it before we did the testing, but it's very tempting while you're seeing those numbers in front of you to say, that's it, that's the problem, and this is what the solution is. It's very, very hard not to attach the value to those numbers when you have gone through all of that. And I wish as a physician that I could tell them, yes, I found it. I'm the hero. I found the problem. I know how to fix it, but we just don't have the evidence to say that conclusively.
Mm-hmm. Yeah, I mean, I think more than anything, these are just super, super important conversations to have with your doctor, because while it's tempting to try everything and just to do all the things all the time, right from the get-go, we really are focused on avoiding treatments that don't actually help and may actually add more burden in a bunch of different ways.
So we don't want this episode to feel discouraging. The immune system is incredibly complex. There is a lot of research happening. Scientists are still learning about the uterus, the placenta, and how the immune system interact. We know that immune factors matter. There's no question about that. The question is, can we measure them in a way that is meaningful, and can we intervene in a way that truly helps?
Hopefully, someday soon, we may be able to tailor immune therapies more precisely. So instead of giving treatments to everyone with recurrent implantation failure, we're going to be able to identify particular subgroups that truly benefit from certain treatments. But honestly, we're just not there yet.
To summarize this episode, if we can attempt to do that, we talked today about the leukocyte antibodies and how they act as blocking antibodies to protect the embryo from being discovered by the immune system. However, we know that testing for them isn't reliable. And LIT, which is a procedure using the partner's white blood cells to trigger tolerance, it's not considered the standard of care in recurrent pregnancy loss or implantation failure. We also learned that it's not available in the United States. There are some clinics around the world that do them, and here at American Fertility Center, we do offer it, but we recognize that it's not the standard of care. We offer it under investigation and with very, very extensive informed patient consent.
We know this is a tough topic, especially for patients who've experienced repeated loss or failed transfers. And we want to recognize you and tell you that your feelings are absolutely valid. And your curiosity about the immune system and immune factors is completely understandable. And we are happy to have these discussions with you, with our patients.
On the next episode in this immune protocol series, we're going to be exploring other immune therapies that you may have heard of. For example, intralipids, immunoglobulin, and steroids. We're going to talk about what the evidence says about them and how they're used in clinical practice. So stay tuned.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at myconfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes.
We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss.
Music by Mixkit. Life is a Dream by Michael Ramirez C.
My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.